Bien, bah écoutez, en premier lieu, bonjour à toutes et à tous et merci beaucoup pour l'invitation. C'est un grand plaisir, un grand honneur d'être parmi vous aujourd'hui pour parler de résistance aux antibiotiques dans cette semaine évidemment extrêmement importante pour la mobilisation globale, hein. Donc moi, mon nom, c'est Jean-Yves Madec, je suis vétérinaire de formation, je travaille à l'ANSES. L'ANSES est une agence de sécurité sanitaire en France qui s'occupe de santé en général, santé de la population, et qui fournit des avis au pouvoir public sur les différents enjeux de santé liés aux personnes, donc sur des champs de santé alimentation, santé environnement, santé au travail, etc. Et bien sûr, la résistance aux antibiotiques fait partie des enjeux importants, et moi, je suis responsable, donc en tant que directeur scientifique, de ce sujet au sein de l'ANSES. Je suis basé à Lyon et donc je vais vous présenter en quelques diapositives rapidement les progrès que nous avons faits, notamment dans le secteur de la santé animale, puisque c'est mon secteur, périmètre d'action, mais bien sûr dans une dimension, une seule santé, puisque c'est comme cela qu'il faut voir ce sujet, bien sûr. Alors, en France, un plan de lutte contre l'antibiorésistance a été mis en place par les pouvoirs publics chez les animaux depuis 10 ans. Et donc, ce qui est intéressant aujourd'hui, plus particulièrement, qui a été mon choix, c'est de vous présenter ces résultats de la politique publique et de la façon dont on peut les analyser. Alors, la diapositive suivante vous montre... Ah, je crois que ça a sauté.
OK, je ne sais pas si vous avez entendu, normalement, il faut que vous fassiez, voilà, on a votre, normalement,
Ah,
c'est vous qui
c'est à
êtes
moi de
dessus.
passer les diapos, c'est ça?
Normalement, vous faites il y a partage d'écran.
Ah, mais je croyais, parce que j'ai envoyé mes diapos ce matin et je croyais que c'était autrement qu'il fallait faire.
Non, non,
Sinon,
mais
je le
c'est pas
fais.
grave, on va trouver une solution. Alors, on a
Ah, mais attendez,
actuellement,
attendez, je vais le faire, pas de souci.
parfait, Tobias,
Je vais le
ça va
faire
être
parce que
fait.
ce matin, enfin, j'ai reçu un mail
Voilà, alors
pour.
comme ça.
Alors, est-ce que vous. Alors, attendez, on va partager l'écran.
Voilà, parce que comme ça, vous pourrez partager.
Est-ce que là, vous voyez mon
Voilà,
écran?
oui, ça c'est le premier.
Si je le mets en plein écran, vous le voyez toujours, parce que des fois, il y a des blagues.
Alors, juste un petit, voilà,
Ça
parfait.
marche?
Merci beaucoup.
Bon, mais très bien. Alors, on va passer à la diapositive 2, c'est bon?
Oui, parfait.
Bon, mais parfait. Bah, écoutez, ici, je vous montre les données qu'on a en France
Donc, vous
sur
pouvez passer à la diapositive
l'exposition
2.
de la population aux antibiotiques. Et vous voyez, on a une différence extrêmement intéressante entre les animaux et les hommes, puisque la France se place
Alors,
au-dessous de la moyenne
est-ce que vous
européenne.
pouvez passer,
Allô?
excusez-moi, est-ce que vous pouvez passer à la diapositive 2? Parce que
J'y
là,
suis.
alors, alors, vous devez remettre en présentation et comme cela, nous pourrons voir défiler vos Voilà, ça va très bien.
Ça va mieux
Ouais,
comme
ouais,
ça?
ouais, voilà.
Bon,
Animals.
on va rester
Animals.
comme ça, hein.
Voilà.
Alors, voilà.
Parfait.
Oui, donc je vous disais que ça, ce sont les données de l'exposition aux antibiotiques des animaux et des êtres humains en France. Et vous voyez que on est dans une position beaucoup plus favorable chez l'animal, puisque la France est au-dessous de la moyenne européenne chez l'animal, alors en consommation d'antibiotiques, hein, en exposition des animaux, par rapport à la médecine humaine, où la France est encore bien loin au-dessus de la moyenne européenne, puisqu'elle est derrière la Grèce, la Roumanie, la Bulgarie, et ensuite vient la France. Alors, le travail qui a été fait chez les animaux est extrêmement important. Vous savez que les animaux dans le monde consomment 70% des antibiotiques, donc c'est extrêmement important de s'attaquer à ce secteur. Et vous avez ici la diminution de la consommation d'antibiotiques chez les animaux depuis 2006. Et vous voyez que ça commençait déjà à descendre depuis 2006, 2007 on va dire, et que la politique publique qui a été mise en place en France, qui s'appelle éco-antibio, 2 fois 5 ans, et on aura probablement un éco-antibio 3 très prochainement, a renforcé cette diminution de l'usage des antibiotiques en médecine vétérinaire. Alors, ce que vous pouvez remarquer aussi, c'est que vous avez ici 3 couleurs différentes. Vous voyez que ce qui est violet a très peu baissé ou pas du tout baissé, on va dire, et que les progrès ont été faits sur ce qu'on appelle les poudres orales et les prémélanges, c'est-à-dire sur tout ce qui est l'administration par voie orale des antibiotiques. Voilà. Donc ça, c'est extrêmement important. Ça a été une marge de progrès extrêmement forte. Et effectivement, bon, les autorités publiques en France sont fiers de ce résultat-là. Alors, si on regarde les chiffres factuellement, aujourd'hui, pour l'ensemble des espèces animales en 2021, donc ce sont les données de 2021 qu'on rapporte l'année suivante, bien sûr, on a une consommation totale de 371 tonnes d'antibiotiques en médecine vétérinaire, c'est-à-dire moins de 10% par rapport à l'année précédente et moins de 60% par rapport à 2011, qui est le début du plan éco-antibio de lutte en médecine vétérinaire. Et vous voyez que si on remonte encore plus haut, on est à moins 72% par rapport à il y a environ une vingtaine d'années. Alors, regarder l'exposition en tonnes, c'est une chose, mais ce que nous, on préfère faire, c'est de regarder les indicateurs d'exposition. C'est-à-dire que vous avez évidemment des antibiotiques qui sont beaucoup plus actifs que d'autres, et que donc, lorsque vous comparez 1 gramme de tétracycline à 1 gramme de ciprofloxacine, vous n'avez pas du tout le besoin de la même quantité de cet antibiotique versus l'autre pour avoir un effet. Donc, il faut, quand on regarde l'exposition aux antibiotiques, avoir un indicateur qui tienne compte non seulement de la masse, c'est-à-dire de la tonne ou du gramme, mais également de l'efficacité, du nombre d'animaux traités, de la voie d'administration. Et donc, il y a un indicateur qui a été créé pour ça, pour être plus représentatif de l'exposition des animaux. Et vous voyez que si on regarde ça pour les différentes espèces animales, on voit une diminution de l'exposition forte pour un certain nombre d'espèces. Par exemple, en volaille, on le voit très bien, en porc, on le voit très bien. Et on voit qu'on a plus de difficultés dans d'autres espèces, comme chez les bovins, où on voit une forme de plateau. Et puis, vous voyez que chez les chats et les chiens, on voit presque même, enfin, même pas presque, on voit une augmentation de l'exposition des animaux. Et la baisse que je vous ai donnée tout à l'heure, c'est une combinaison de tout ça. Donc, vous voyez que c'est important d'aller un petit peu dans les détails. C'est un peu comme si en médecine humaine, on regardait tel service, tel type de pathologie par rapport à d'autres. Il y a des secteurs dans lesquels les résultats sont extrêmement positifs, d'autres où ils sont encore avec des marges de progrès. Alors, l'équilibre fait que globalement, on a une très forte diminution de l'exposition des animaux. Il faut dire aussi qu'en France, les porcs et les volailles consomment la majorité des antibiotiques. Donc, c'est assez heureux d'avoir une exposition des animaux diminuée dans ces deux filières. Alors, lorsqu'on veut s'attaquer à la diminution d'exposition aux antibiotiques par les animaux, on peut évidemment prendre tous les antibiotiques un par un, mais vous savez qu'il existe des antibiotiques d'importance critique, et donc pour l'homme, bien sûr, et donc ce qu'a fait cette politique publique, c'est de s'intéresser en premier lieu aux antibiotiques d'importance critique que sont les céphalosporines de dernière génération, à large spectre, et les fluoroquinolones. Voilà les deux grands antibiotiques qui sont évidemment dans tous les classements de toutes les institutions, organisations internationales, OMS, etc., en tête de ligne sur lesquels il faut faire des efforts en médecine vétérinaire. Et vous voyez que là, les efforts sont extrêmement forts, avec une baisse de moins 93% ou moins 87%, c'est-à-dire en gros 90% de l'exposition à ces molécules a disparu en France pour la médecine vétérinaire. Donc ça, ce sont vraiment des résultats extrêmement encourageants. Aujourd'hui, un vétérinaire utilise quasiment plus de céphalosporine à large spectre et de fluoroquinolone. Alors, la baisse d'exposition aux antibiotiques, c'est évidemment une chose, mais il faut s'assurer que ça entraîne une baisse de résistance aux antibiotiques. Et c'est pour ça que je vous ai présenté dans un premier temps ce dispositif de surveillance de l'exposition aux antibiotiques, mais maintenant je vais vous présenter la façon dont on regarde l'efficacité de cette baisse d'exposition, et c'est ce qu'on appelle le réseau RESAPAT que vous avez cité tout à l'heure. Donc le réseau RESAPAT, c'est un réseau de surveillance nationale qui est fondé sur la collecte des données venant des animaux malades. Ces animaux malades sont vus par des vétérinaires qui ensuite font des antibiogrammes pour regarder au moment de l'infection la nature résistante ou non de la bactérie qui est responsable de l'infection, et ceci dans l'ensemble des filières animales, hein, de toutes les espèces animales. Ça se fait dans des laboratoires, donc vous avez 101 laboratoires en France qui font cela pour la totalité des vétérinaires, et l'ANSES collecte ces données, ce qui lui permet de faire des courbes, d'analyser les tendances d'évolution par bactérie, par antibiotique, par espèce animale et par pathologie. Et donc, je ne vais pas évidemment vous présenter l'ensemble du rapport. D'ailleurs, ce rapport est en ligne, hein. Il suffit d'ailleurs de taper sur Internet Resapat et vous allez très facilement tomber sur une version française et une version anglaise de ce rapport qui est édité chaque année. Et je vais vous donner deux exemples qui font écho à ce que je vous ai dit précédemment sur la diminution de la résistance de l'exposition aux antibiotiques d'importance critique pour l'homme, donc les céphalosporines et les fluoroquinolones. Alors, si on regarde d'abord les céphalosporines, ben, vous voyez qu'en parallèle de la baisse extrêmement importante de l'exposition des animaux, on a une baisse extrêmement importante aussi, alors là j'ai mis uniquement depuis 2011, de la résistance, puisque aujourd'hui on peut considérer que les Escherichia coli, les entérobactéries, puisque principalement représentées par la bactérie Escherichia coli, les entérobactéries résistantes aux céphalosporines de dernière génération en France, dans les différentes espèces animales, sont soit proches de zéro, hein, vous voyez les courbes jaunes, orange et bleues, soit entre 0 et 3, soit au maximum entre 6 et 8 pour l'ensemble des espèces. Donc, ce sont des résultats extrêmement intéressants. Et donc maintenant, le challenge, c'est de maintenir ce bas niveau de résistance sur le long terme. Et si on regarde les fluoroquinolones, on a exactement les mêmes courbes. Alors, exactement pas tout à fait, parce que vous voyez que les dynamiques sont un peu différentes, mais ce sont des antibiotiques qui sont aussi différents, donc les mécanismes de résistance sont différents, les bactéries ne réagissent pas de la même façon à ces antibiotiques-là, mais vous voyez qu'il y a une convergence de l'ensemble des courbes depuis des niveaux extrêmement élevés. Vous voyez, chez les bovins, on était à 25% de résistance aux fluoroquinolones au début du plan, et maintenant toutes les courbes convergent à environ 5% et parfois moins pour un certain nombre d'espèces animales. Donc, on voit qu'on a une très, très bonne corrélation entre la baisse d'exposition et la baisse de résistance. Donc, c'est à la fois une preuve que ça marche, une preuve que quand on diminue l'exposition, on arrive à diminuer la résistance. C'est une évidence pour tout le monde, encore faut-il y arriver. Donc, ici, on a cette belle corrélation qui est aussi possible de mettre en évidence parce qu'on a des dispositifs qui permettent de suivre l'exposition d'une part et de suivre la résistance d'autre part. Et ce dernier dispositif est donc le Resapat. Alors, juste pour terminer rapidement sur ce que ce Resapat donne comme information extrêmement intéressante, vous savez peut-être que la résistance aux antibiotiques chez les animaux malades n'est pas du tout coordonnée au niveau de l'Europe. Et le Resapat est un système national qui mériterait d'exister dans d'autres pays pour qu'on ait ensuite une coordination de l'ensemble des dispositifs à un échelon européen. Et donc, comme le Resapat est le dispositif le plus constitué, le plus consolidé en Europe dans un pays donné pour surveiller la résistance aux antibiotiques chez les animaux malades, nous avons porté ce concept dans le cadre d'une action conjointe européenne pour essayer de faire, d'abord pour faire un inventaire des dispositifs ou des systèmes ou des façons de faire qui existaient dans chacun des pays pour surveiller l'antibiorésistance chez les animaux malades, et ensuite d'essayer de développer un concept unique, on va dire, ou réunificateur entre les différents pays. Et ce travail-là a été fait dans le cadre de cette action conjointe qui s'est terminée en 2020, mais qui sera prolongée dans le cadre d'une deuxième action conjointe qui est en construction au niveau de l'Europe, avec un objectif de mettre en place ce qu'on pourrait appeler un Resapat-like ou un Resapat européen, sachant que le but n'est pas nécessairement d'exporter un modèle, mais plutôt d'exporter une vision, une nécessité. Et évidemment, on travaille avec tous les pays pour que le modèle européen puisse être la bonne convergence des différentes complexités, diversités qu'il y a dans chacun des pays. Vous savez aussi que, contrairement à ce qui se passe en médecine humaine, chaque pays n'a pas les mêmes productions vétérinaires. On a plus de bovins dans tel pays, plus de porcs dans d'autres, les tailles des agricultures sont différentes, donc il y a besoin de tenir compte et de respecter la diversité de ces productions, mais il y a une nécessité d'avoir une coordination pour avoir des données européennes sur la résistance aux antibiotiques et les tendances de résistance aux antibiotiques chez les animaux malades. On a appelé ce réseau en construction IRSVET par analogie avec ce qui existe en médecine humaine et qui s'appelle IRSNet. Et donc, on peut imaginer que dans quelques années, lorsque ce réseau sera pleinement opérationnel en Europe, on puisse faire des parallèles, des croisements, des analyses intégrées, des analyses conjointes entre ce qui se passe en médecine vétérinaire et ce qui se passe en médecine humaine. Voilà les quelques mots que je voulais vous dire aujourd'hui sur la situation de la France, qui est plutôt favorable dans ce secteur-là, qui porte cette ambition-là au-delà de la France et même au-delà du secteur, bien sûr, vétérinaire, puisque, comme chacun le sait, l'antibiorésistance est un sujet, une seule santé qu'il faut traiter conjointement entre les différents secteurs. Voilà. Et je vous remercie beaucoup de cette opportunité que vous m'avez donnée de vous présenter ces éléments-là et j'aurai plaisir à éventuellement répondre à des questions si vous en avez. Merci. J'entends rien du tout. Vous m'entendez? Non?
On vous a très bien entendu, hein.
Ah, ça y est, je vous entends.
Voilà. Alors, je disais que si ça ne vous dérange pas, on va procéder comme ce matin, c'est-à-dire qu'on va entendre une autre intervenante et après, nous allons récolter les questions dans la salle et en ligne. Est-ce que ça vous convient? Est-ce que vous avez le temps?
Oui, très bien. Là, donc, ça veut dire, comme on a commencé un petit peu en retard,
vers 14h35 14h35, ça irait? Ou vous voulez prendre des questions tout de suite?
À la limite, s'il y a des questions tout de suite, je veux bien les prendre.
D'accord, ok, on procède comme ça. Alors,
voilà.
Est-ce qu'il y a déjà des questions dans la salle? Attends. D'accord. Pas encore, oui. Alors, moi, j'ai juste une question. Lorsque vous avez précisé le tonnage, 371 tonnes, 371 tonnes en 2021, en médecine vétérinaire, quelle est une comparaison avec le monde de manière mondiale? Parce que avec le chiffre seul de la France, on ne voit pas très bien où ça se passe, où ça se positionne. Merci.
Alors, les chiffres sont... Alors, effectivement, je ne voudrais pas vous dire de bêtises. Les chiffres les plus élevés, je ne voudrais pas vous dire de bêtises en chiffres exacts, mais les chiffres les plus élevés se trouvent dans des pays comme la Chine, par exemple. Hein. Et par contre, en médecine vétérinaire, par contre, mais je peux regarder entre-temps d'ici là pour vous donner les chiffres exacts. Voilà. Par contre, le tonnage en médecine vétérinaire en France aujourd'hui est inférieur au tonnage en médecine humaine en France. C'est-à-dire le tonnage en médecine humaine, il est de l'ordre de 420, je crois, tonnes pour la médecine humaine.
Très bien, mais ce serait bien que pour faire une comparaison
au
niveau mondial, on puisse avoir une différence avec, par exemple, vous venez de mentionner la Chine, qu'on sache quel est le tonnage qui signifie un chiffre élevé. Alors, Garance.
J'ai entendu des rumeurs parisiennes qui me parlaient d'une réduction importante du budget de l'ANSES. Est-ce que c'est vrai? Ça paraît très dommage parce que vous faites un travail qui est remarquable en France, enfin c'est des bons résultats.
Écoutez, j'ai pas eu vent de ces rumeurs, peut-être que je les ignore, mais j'espère pas. Non, j'ai pas de données par rapport à ça, mais on serait très heureux effectivement de pouvoir continuer ce qu'on fait.
Alors, donc, si vous avez quelques minutes, il y a Viviana qui va parler du même problème pour le Sud global. Elle va parler 10 minutes, si vous pouvez rester encore.
Oui, très bien. Alors, c'est très bien.
Merci beaucoup.
Et alors, une autre question. Vous avez beaucoup parlé naturellement du Résapat ce réseau européen de surveillance en médecine vétérinaire, est-ce qu'il y a des équivalents à votre connaissance pour d'autres continents ou régions?
Je ne pense pas, et c'est justement ce qu'on voudrait pousser, puisque j'ai également la chance d'être le responsable du centre de référence pour la FAO sur l'antibiorésistance, et donc nous travaillons avec un certain nombre d'autres pays, notamment le continent africain, et nous portons des actions de renforcement capacitaire dans les laboratoires, c'est-à-dire en faisant des audits, en faisant des essais interlaboratoires d'aptitude pour que les laboratoires puissent être au bon niveau de diagnostic de l'AMR. Et donc ça, c'est la première étape, d'être sûr d'avoir des bonnes données pour ensuite pouvoir les collecter et en donner le sens. Donc, c'est ce qu'on a fait pour le Résapat. On a commencé à mettre les laboratoires dans un standard de qualité et ensuite, on collecte les données pour pouvoir les interpréter. Si les standards de qualité sont mauvais dès le départ, ne sont pas satisfaisants, on a beau collecter des données par un réseau, on ne pourra pas en dire quelque chose de fiable. Donc, notre stratégie, c'est de faire ça et on est en train de faire ça dans le cadre de laboratoires qui souhaitent acquérir ces standards. On est prêt à les aider et dans le cadre de ce mandat de centre de référence, on a proposé nos services pour aider un certain nombre de laboratoires de pays pour monter à ces standards qui sont donc encore une fois la première pierre pour avoir un réseau fiable de surveillance.
Parfait. Alors je rappelle pour ceux qui ne le savent pas que la FAO fait partie du réseau des Nations Unies. C'est une organisation internationale basée à Rome qui s'occupe d'alimentation et d'agriculture. Alors on va passer maintenant à l'intervenante suivante, Dr. Viviana Munoz-Teles from the South Center. Are you connected with us, Doctor?
I am.
Okay.
I hope you can hear me.
Yes, very well. Thank you. Thank you for being with us online. You are the coordinator of the Health, Intellectual Property and Biodiversity program, and you're part of the Global South Global South Center based in Geneva, and you are going to speak about reducing antimicrobials in animal farming, policies for the Global South. So the floor is yours, Doctor.
Thank you very much. I'll try to keep to the 10 minutes following that excellent presentation by Jean-Yves. So I will be talking to you about a particular policy paper. Just to set the context to mention, I mean, our work at South Center, we're a think tank for developing countries. We have 55 members and work with the larger membership of developing countries. And antimicrobial resistance has been a theme that we've been working strongly in the past 10 years. So part of our work has to do with the international system, working with the international UN agencies and others. And part of our work is really capacity building at the regional and the national level with different countries. So one of the issues that I'll be just referring to today is with regards to how can we have some effective policies and incentives for developing countries in particular to reduce the use of antimicrobials, in particular in the production of food animals. So of course, the approach, as others have mentioned already today, is really One Health. There's different aspects of the impact on antimicrobial resistance on human health, and the food chain is one of these. In terms of international legislation, there is some guidance provided by the Codex Alimentarius and by the previous OIE, which is now the World Animal Health Organization. But in practical reality, there's a lot of different practice and implementation in respect to countries. And as Jean-Yves also mentioned, in the case of Europe as well. So there's a lot more in terms of what needs to be done at country level. So one of the problems is really also that we don't have a clear picture of the consumption and use of antimicrobials in animal food. So for example, a general estimate that I have heard is about 130 plus 130,000 tons of antibiotics used in animals, and that being about perhaps even up to 70% compared to the global use also of antibiotics in human health. But we really don't have more than these general estimates. And this is partly because we don't have that data collection and systems of surveillance developed in most parts of the world. So this is, for example, from one of the WHO, FAO, and what they aim to do as a joint survey, where they're asking countries to self-assess on different questions. And with regards to the use of consumption and use data, you can see that there's many countries, those in red, that says that they are not making use of that data, whether because they don't have it available or it's not informing their policies. If we look at surveillance data to inform decisions, also many countries here in red say that they are not informing those decisions based on any surveillance data that they have for food production. Clearly, you see much more advance in Europe in those responses, and well, responses so as far as United States as well, and Canada. Now, on the question of whether countries are starting to have integrated surveillance systems for antimicrobial resistance that would include the food sector, you see many countries saying that, yes, there are efforts here, you see in blue, but still many countries, in particular in Africa and Latin America, still do not have integrated surveillance. And these are our plans for starting the systems, not even that the plans are already established. So there's a lot more to do in terms of surveillance to have a good picture of what is the situation on consumption and use. Now, what have countries said are key elements why they have difficulties in this area? So this is the general annual report that's done, and many countries report that they don't have regulatory framework in place, they don't have sufficient cooperation among the agencies, they lack tools, including, of course, for example, laboratory capacities, and other issues that affect their capacity to produce and have surveillance adequately. So in terms of responses, we see that the use of antibiotics for growth promotion, while it has reduced all over the world, leading, of course, Europe, since the legislation has been in place to ban growth promotion use of antibiotics since 2006, you see that there has been progress, at least in those reporting some countries, but it still remains very high in the Americas and Africa and Asia and Far East and Oceania. So we should not be seeing at all any countries allowing the use of antibiotics for growth promotion. In terms of the use in Geneva, already mentioned it in France, the same picture. This shows, according to this data of the World Animal Health Organization, the global picture of countries responding to which antibiotics are mostly being used in animals. And you do see that on the right side, which is the classification aware of WHO, of which antibiotics are critical of high priority for human health, that there is interaction between the use of antibiotics in animals and those that would be critical for human health, in particular in penicillins. And you see, well, high numbers reported for the uses tetracyclines, which are also used in human health. Now, in terms of the consumption data, there is, of course, lack of information here. So this is just from the self-assessment surveys. But this just comes to show that there's a very big use in Asia and in the Americas, much less so at least reported in Africa. And that would be the case if we consider that there's more small scale production versus large intensified farming of animals in the Americas and Asia. And then we see, of course, Europe leading in that effort that has been for more sustained years to reduce use of antibiotics in animal food. So just to quickly mention that what you might find in that paper that I presented at the beginning is that we see as South Center that there is an opportunity to use the context of the new EU regulations with regards to reducing overall use of antimicrobials in animal food production in the EU, as also a tool to see if we can push for more antibiotic stewardship in animal foods in developing countries. But this will require not only a stick approach, which means basically the enforcement of this regulation on imports, which is the case. These EU regulations that now will ban the routine use of antimicrobials via medicated feed and growth promotion, which was already the case. but also for preventative treatment of individual animals or groups of animals except in exceptional cases. And it will also make it illegal to give antibiotics to farm animals to compensate for inadequate husbandry practices or biosecurity deficiencies. And this is particular when you have intensified farms and that might not give priority to animal welfare. And it also creates new requirements at European level for data collection and reporting. And this will nonetheless allow for a phase out because not all countries in Europe, of course, are already at the same scale as France, for example, in the systems for collecting information with regards to sales and use. Now, so the relevance for developing countries is the fact that this regulation also addresses imports of animal-derived products. That means exporters from developing countries to the EU will have to comply with the regulation. And the imports cover two parts of the bans of the EU. It does not, however, cover that requirement that says that there cannot be any routine use for antimicrobials for preventive purposes or to compensate for poor husbandry. But exporters will be held to the EU regulation with regards to any use of antimicrobials for growth promotion. So this requires, for example, a sampling of farms that will be doing the exports to ensure that these are not being used, and also the relationship to those listing of designated antibiotics that are only for human medicine. And so some of these elements are still to be developed. The legislation, of course, is already in place, but the particular, for example, elements of the listing of which are the antibiotics, that those are still to be defined. So what are we suggesting? We are suggesting on the one hand that this should not be seen from the perspective of developing countries simply as a trade barrier. There have been already discussions in the World Trade Organization of some countries, including the United States, questioning the EU regulations as potential barriers to trade. While at Cell Center, we're very sensitive to those concerns of developing countries, on the other hand, we would like to highlight that the EU regulation can set a good standard in the sense of where should countries try to aim in terms of reducing antimicrobial use in animal food production. And what we have to see is what is the pathway for a transition? How can we support these countries moving forward to meet those expectations? And also to make use of the opportunities for export for those producers that will be able to meet the EU standards. So we do see already changes, for example, in Thailand and some other exporting countries that are already switching their current practices in order to continue to benefit from the EU market. And this is also taking into account the size of the EU market and the importance for many of these exporters. So some of our recommendations is for the EU. I'll just highlight those here. The EU could be thinking about, to avoid partly that backlash of trade measures from third countries, it could be already also designing a plan of how to support compliance and that transition from developing countries towards being able to continue to enter the EU market for animal food products. This can include, for example, transition periods. So far, none have been announced with regards to the import restrictions, and also facilitated technical assistance, for example, in terms of what are best practices that are being done in Europe, as well as technology transfer in multiple areas, even, for example, on wastewater management that we heard today is so essential, and that would really have a strong impact in many developing countries. So thank you very much. And in our website, you can find the paper and our references for any future questions. Thank you.
Thank you. Thank you so much, Dr. Viviana Munoz Teles. I kindly remind the viewers and the people in the room that you are working for the Global South Center based in Geneva. Is there any question online and here in the room? Would you like to address a question to Dr. Viviana Munoz or to Dr. Jean-Yves Madec? No, I have a question.
Je peux avoir un commentaire?
Oui, je vous en prie, docteur, je vous en prie.
D'abord, merci beaucoup à Viviana pour avoir extrêmement bien expliqué la situation sur les antibiotiques à une échelle mondiale. Pour revenir sur la question de tout à l'heure, les chiffres d'exposition aux antibiotiques en Chine, par exemple, sont fluctuants, mais on se parle de plusieurs dizaines de milliers de tonnes. Donc, alors évidemment, il faut comparer ça à la population animale, hein. Bien sûr, on ne peut pas comparer la France avec la Chine, mais effectivement, la Chine est l'un des pays les plus utilisateurs d'antibiotiques en médecine vétérinaire. Ce qu'il faut extrêmement dire, et ça a été dit par Viviana de façon extrêmement claire, l'Europe a depuis 2006 interdit l'utilisation des antibiotiques en facteur de croissance. Et ça, c'est quelque chose qu'il faut pousser au niveau mondial. Il y a de nombreux pays, la majorité des pays qui utilisent les antibiotiques comme facteur de croissance, c'est-à-dire dans un traitement préventif des animaux, indépendamment d'un contexte de soins. Il y a des pays de niveau à ressources différentes, puisque même les États-Unis utilisent aussi les antibiotiques comme facteur de croissance. Donc, s'il y a un message général à l'échelle du monde à porter, c'est celui d'arrêter l'utilisation des antibiotiques en dehors d'un contexte de soins. Mais évidemment, Viviana a extrêmement bien expliqué que les antibiotiques, dans cette utilisation-là, étaient aussi là pour compenser des déficits d'élevage et d'organisation du soin, de l'organisation des élevages, donc des problèmes zootechniques et d'organisation. Donc, on ne peut pas juste dire à ces pays, enlevez les antibiotiques et tout ira mieux, parce qu'il faut aussi les aider à renforcer leur capacité à élever des animaux sans antibiotiques. Et ça passe par autre chose que les antibiotiques. C'est renforcer la capacité d'élevage. Donc, je suis tout à fait d'accord qu'il faudrait travailler sur des soutiens à la transition des systèmes d'élevage dans les pays à ressources limitées. Et par contre-coup, on aura une diminution de l'utilisation des antibiotiques. Si on ne fait que l'un, c'est-à-dire si on agit que sur les antibiotiques, on ne va jamais arriver à baisser de façon significative l'utilisation des antibiotiques.
Merci beaucoup, docteur. Question en ligne ou dans la salle? Rien pour l'instant. J'ai une question. I have a question for you, Dr. Viviana Munoz. This is regarding what you just mentioned about supporting the countries, in fact, to change support that the EU should support measures for developing countries, in fact, to match the EU regulation regarding antibiotics. So I would like to know what the position is of WTO, the World Trade Organization. Is there anything in the programs or any discussions on that?
Thank you. The main international agency supporting in this area is really the Food and Agriculture Organization of the United Nations, together with the World Animal Health Organization and in collaboration with the World Health Organization. The World Trade Organization has not really gotten involved in the issue. Where we see this debate taking place is in a committee of sanitary and physiosanitary measures. And there have been questions about whether the EU regulations are in compliance with that agreement. And there's divergent views that has just been raised as a question, in particular by the United States. But the WTO is not really providing any kind of technical assistance within the broader scope of what was being mentioned. It's more the FAO and World Animal Health Organization that work directly with veterinary focal points, for example, and really assist on the ground in what needs to be done in improving animal husbandry practices, as well as even for the systems for surveillance and monitoring to have some data about what's the situation on antimicrobial use and resistance in animals and the linkage with human health.
I understand, but my point was more the fact that if you stop certain importations, food importation, animal importation, because they're not matching the rules, you in fact stopping the exportation of certain countries that are absolutely unable to match the measures, the EU measures. That was the reason why I thought that there could be a link with WTO.
Yeah, you're right. That's why that's that discussion in the committee in WTO, but it's not about the Secretariat support. It's more about member states then discussing and even potentially bringing up some sensitive issues in that committee between them about the application of the measures. But we have to wait and see first what will be the outcome of how they will be implemented in EU before we can see, how countries are reacting as well.
Okay, thank you so much. Any other question in the room or online? No? Okay, so thank you so much to both of you, Dr. Munoz, and also to Dr. Jean-Yves Madec. Merci beaucoup pour votre participation à tous les deux. And we'll turn now to the team of Professor Amy Pruden, Virginia Tech University, United States of America. Is Professor Amy Pruden connected? We'll check that.
Okay, it wasn't allowing me to unmute my microphone.
Okay. Hello.
I'm here now.
Yeah, good morning for you, I suppose. Oh.
Good morning.
Thank you, Professor, to be with us. So you are going to speak about the surveillance systems and the urgency of access to wastewater treatments. We did speak about wastewater this morning, but more in Africa or in Europe, so it would be very interesting to hear you, and particularly after your participation to a meeting that took place recently, was it in Norway, Garance?
Sweden.
In Sweden, is that correct? The EDAR6 is a meeting that took place in Sweden. So the floor is yours, Professor, and thank you again for being with us.
Well, thank you for having me. Can you see my slides okay?
Yes, perfect. Thank you.
Okay. So I'd like to speak some about the potential for wastewater surveillance of antimicrobial resistance, and especially our work on metagenomic-based surveillance. And it's important to recognize the context of the COVID-19 pandemic. And in response to this pandemic, it's really remarkable that this infrastructure emerged all over the globe for sewage-based monitoring of the virus. And now it's being recognized that there's great potential to use this infrastructure to monitor for other public health threats. And this includes antimicrobial resistance. Here in the US, the CDC is investing in research to advance sewage-based monitoring of public health threats. And we recently were awarded a project from CDC to work on this. And of course, we're all here because antimicrobial resistance is the next pandemic. It's ongoing and it's urgent. I wanted to highlight this study that was published in The Lancet simply to point out the comprehensive nature and the difficulty in gathering the amount of data and analyzing it to recognize the trends that can inform our understanding of the problem and potential solutions. This article had many authors and looked at 204 countries and territories, 23 pathogens, 88 pathogen drug combinations, but this was really essential information to give us insight into the scope of the problem. And so they estimated that there's 4.95 million global deaths per year associated with bacterial AMR. And to put that in context, in 2020, it was estimated by the World Health Organization that there are about 3 million deaths due to COVID. So in our research group at Virginia Tech, we have been monitoring sewage for some time for antimicrobial resistance markers. And in 2019, my collaborator, Li-Ching Zhang in computer science, approached us and came up with the idea that we should be looking at the sewage for antimicrobial resistance markers and really scale this up in terms of the cyber infrastructure needed, and that could inform public health dashboards and to be a valuable policy tool. So shortly after that is when the COVID-19 pandemic took root, and suddenly there was this great interest in sewage surveillance. But it's important to point out that AMR is much more complex than just the SARS-CoV-2 virus. So like I pointed out, the Lancet study looked at multiple bug-drug combinations. The comprehensive antibiotic resistance gene database has over 3,500 antibiotic resistance genes curated. So it is a challenge on what to monitor and where to monitor. And as we think about the answer to that question, it's important to think about what is antibiotic resistance. So we're most concerned with the definition of antibiotic treatment that no longer works to cure a deadly infection. But in terms of what we measure in the lab,
yeah. Hello, do you hear me? Maybe if you hear me, you should reconnect. Oh yeah, okay. Here you are.
Can you hear me now?
Yeah, yeah, perfect.
Okay.
You
My
were just saying
apologies.
what you see in the lab.
Yes. So you can plate the organisms and put these discs with antibiotics, and we know if the organism grows next to that disc, then it's resistant. But we might also look at the genes that encode resistance. We call these ARGs, right? And these encode the actual functions, such as pumping the antibiotic from the cell, modifying the target, and degrading the antibiotic. And these ARGs are also horizontally transferred among bacteria. So if we want a comprehensive understanding across the microbial community, there's advantages to looking directly at the ARGs and not individual microbes. And why sewage and wastewater? Because when we consume antibiotics, they are excreted, and that's where they go. And we're also excreting resistant bacteria and antibiotic resistance genes. But again, some contrast compared to wastewater-based surveillance of the SARS-CoV-2 virus. We're not just interested in looking at the influent sewage, which tells us the carriage in the population. It's also important to look at the effluent sewage to have some idea of forms of antimicrobial resistance escaping treatment, and that might contaminate the water environment and be a source of exposure. And so we're advocating for a systems-based approach across the water cycle, and this can inform data-driven, science-based policy. And you can read more about this idea in our current opinion article that was published recently in partnership with Anna Maria de Roda Hussman, who's worked both on antimicrobial resistance and on monitoring the SARS-CoV-2 virus and sewage. So also around the time that the pandemic was taking root, we were awarded this project from the U.S. Water Research Foundation. And here they asked us to provide guidance on what they should monitor in water and wastewater. And we turned to experts in an online survey, which reached 105 experts around the world. And we also held an expert workshop, which was attended by people from World Health Organization, CDC, USDA, FDA, our US Geological Survey, EPA, various academic experts, and also practitioners from water utilities to give some practical perspective of what was feasible. And this article that was published in Environmental Science and Technology summarizes the perspectives from this workshop. So an important outcome was that there wasn't any one single target that is the one that is most informative for antimicrobial resistance monitoring in the water environment. There are many targets, and it depends on your monitoring objective. And they helped us to narrow it down to 4 monitoring objectives. So the first is the wastewater-based surveillance, telling us about resistant bacteria and resistance genes circulating in the human population. The second would be what is escaping wastewater treatment or agricultural sources into the environment. And the third is quantifying removal rates. So what kind of treatments are most effective? And finally, the fourth is identifying these hot spots in the environment that have the ideal set of conditions for antimicrobial resistance to evolve and spread. So looking at a few specific targets that we could focus in on, the advantage of culture-based targets is that it's the only method where you have a viable organism. You know that it's a living organism. You can confirm that it's a pathogen. You can confirm that it carries antibiotic resistance genes, and whole genome sequencing can help you to do source tracking. And also it's useful to inform human health risk assessment. But the downside is that microbial communities are complex. Most are not culturable, and it's not clear how much one organism will represent the full microbial community. But among our experts, it made sense that E. coli is an organism that is a good target for antimicrobial resistance surveillance. The World Health Organization has developed a standardized protocol called the tricycle protocol. Enterococcus is a good choice because it's gram-positive, and so it complements information from the gram-negative bacteria. But also we should think about whether we should look at other organisms besides these fecal organisms. So for example, Aeromonas and Pseudomonas grow better in the environment, and they might tell us more about the potential for horizontal gene transfer. Quantitative PCR is advantageous in that it quantifies the ARG across the whole microbial community. So it captures markers of resistance among uncultured organisms. And because it's quantitative, it's useful for informing models, including risk assessment. And the challenge again is that there are multiple ARGs to target. Like I said, over 3,500 in the CARD database. And so it was agreed it makes sense to look at a mixture of anthropogenic indicators like SOL1, the class 1 integrase gene, as well as clinically relevant genes encoding ESBLs, carbapentamases. And finally, metagenomics. So there's a great deal of excitement around metagenomics because in theory, you don't have to pick a target. It's a non-target based method. So you can take a sample, extract DNA, sequence the DNA, and see everything that is there. The problem is you don't really see everything because of the random nature of the technique. It has a high detection limit. Much of what ends up being sequenced is not the target that you're interested in. And there's also a great deal of expertise needed and lack of agreement in the data analysis approaches. Yet there is excitement around this method. It has a lot of potential, and even the water utility practitioners recognize that. So just some examples of what we've been able to see from metagenomic sequencing of wastewater. This is a study that we just published in Environmental Science and Technology, where we sampled wastewater from different countries. And we saw that when we ranked the total antibiotic resistance genes, that there was a trend, and that the lowest relative abundance of resistance genes were in wastewater treatment plants from Sweden, and the highest were in the wastewater treatment plants we looked at in Hong Kong and India. And so this tells us that there's some potential here to look at these kinds of trends more deeply to understand the socioeconomic and policy factors driving these kinds of trends. The data I just showed were from short read metagenomic sequencing. There's another category of metagenomic sequencing called long read sequencing. So these are methods like MinION, PromethION, and these provide much longer stretches of DNA sequences and make it possible to identify whether the antibiotic resistance gene is on a mobile genetic element like a plasmid, and that means there's more potential that it could move to a new bacterial host, such as a pathogen. And it also can tell you if it is already in a pathogen. And so in this study, we used long read sequencing to look at influent sewage and to do a network analysis of antibiotic resistance genes with putative pathogen hosts. And so you can see a comprehensive network in the sewage, but in the activated sludge that we tested, the network becomes much smaller. So this is encouraging that in general, the primary wastewater treatment process of activated sludge does act to attenuate antibiotic resistance genes and also their mobility, but there are still ones that do escape, and these are ones we're concerned about. And so in this study, we did an 18-month sampling of a local wastewater treatment plant, and this is just showing you the chord diagram, that's bug-drug combinations of the effluent, influent, and then the regional antibiogram of patients that presented with clinically resistant infections. And this shows that it was actually the treated wastewater effluent antibiogram that had a stronger resemblance to these clinical infections in the community. So it reminds us that it's valuable to also monitor the wastewater treatment plant effluent because it tells us not only what's being removed during treatment, but also could be a clinically relevant surveillance point. And so at this point, we're expanding on this study. We've been sampling twice a week for over a year and doing deep sequencing and annotating for antibiotic resistance genes and pathogens. And we're looking at a few wastewater treatment plants locally that have different socioeconomic considerations in terms of unemployment rate and population. And I wanted to highlight that Connor Brown, who is also attending the meeting and available to help with questions, he's a graduate student. He's been very instrumental in moving this project forward. So these are some of the annotations that he did of antibiotic resistance genes in the influent and effluent. And so you can see that you can identify anomalies. In this case, it was streptogrammin resistance, which is clinically important. But when he dug deeper, it was interesting that this streptogrammin resistance was not carried in any obvious human pathogen, so that was good. It was actually carried in a cyanobacterium, which is interesting and something to consider, whether that is a relevant vehicle for antibiotic resistance genes in the environment. But the other interesting thing here was that he could relate it to wastewater treatment plant operational conditions. Here, the food to microorganism ratio was shifted during that period. And so he's also been digging into the data to look at clinically relevant resistance genes here. He's looking at colistin resistance. And this is just to say that there are multiple forms of colistin resistance and multiple genetic contexts, but we do find it in the effluent of the wastewater treatment plants. And so this is something concerning for future surveillance. And finally, looking at pathogens, These are the 3 different wastewater treatment plants in the region. So you can see there's some different patterns. And again, they relate to operational conditions. So temperature is something that shifts seasonally that we're looking at. But it's important to recognize that the resolution of metagenomic annotations, we can't say for sure these are pathogens, but we can say these are taxonomic groups known to contain pathogens. And finally, we're advocating for data sharing. So we've developed the Water Antibiotic Resistance database, and we hope that this is a useful tool for the community to standardize reporting and sharing of data. And finally, going back to our current opinion article, we articulated many benefits of environmental surveillance of antimicrobial resistance that are listed here. So what is circulating in the community? Could this information in a dashboard directly inform how doctors engage in their prescription practices and what's used in agriculture? This data is very much needed to identify where antibiotic resistance is coming from in an epidemiological sense, and would be very valuable to inform policy. And finally, I just want to make sure people are aware that metagenomic methods are still in their infancy. You'll see many very interesting scientific papers, but there's a lack of agreement in the analysis of the methods. So we do need to work towards standardized, comparable data sets, and this is through the full workflow of how you collect the sample, where you collect the sample, how you concentrate it, extract the DNA. We're advocating for spiking internal standards, and that's what's shown here, is that these internal standards can help the data to be more quantitative, and we do need ways to share the data in a comparable format so that we can maximize the value. And this is going to take governmental and NGO action to coordinate this, but in the end, that's where the benefit will be in terms of science-based policy. And so there's a special issue in environmental science and technology that I think would be useful to this audience. And finally, I thank you all for your attention.
Really great presentation, and it would be really nice of you to share the slides or the content of your slides in order for many of the viewers and people in the room to read them back. I think there must be questions, no, in the room? No? Online? Yeah? You sure? Okay, I have...
Sandrine Baron is in the room, and we were with Amy Pruden in EDA 6, the environmental determinants of AMR. So I'd really appreciate if you would say something, because in Sweden, it was all very high-level science, as Amy is presenting here, and we need to communicate this message to a broader public and to our policymakers. So I would really like to hear from you, from your thoughts, Sandrine. I know you have a train to take in a few minutes, so before you leave, just say something, please. What do you think?
I say thank you. No, thank you in my mind. No. Yes, I follow your communication in EDA, and it was a very interesting thing. But in EDA, only focus on the impact of wastewater in the reception ecosystem, and not for a long time what's happened after just the output of the wastewater. And your presentation now, it's very interesting because we have to take all the system into account. And what I am very interested by is the use of the target bacteria or something like. And I'm not sure that E. coli is the best, because E. coli is not autochthonous bacteria of the aquatic environment. Of course, it's a fecal contamination indicator, yes. They harbor a lot of virulence or antimicrobial resistant genes, but I am more interested by autochthonous bacteria from the aquatic environment, like Aeromonas, like you mentioned, because I think this type of bacteria can be used as a sentinel or an indicator, because we can find it not only in wastewater, but in fresh water and in saline water. So what about your opinion about using more autochthonous aquatic bacteria than fecal bacteria?
Yeah, yes, to complete the question, why you are not using the total enterobacteria? You are using E. coli and Enterococcus, or you can also make the monitoring with total gram-negative enterobacteria. Another question is to know, after the monitoring in the wastewater, in the receiving system, you are using also the sediment, or just you are only in the water column? And what can be the impact of antibiotic resistance genes or bacteria in the living organisms such as fish under your experience conditions?
I mean, all kinds of questions, Professor. The floor is yours.
For me?
Yes, please.
Wow, these are all very good questions. So we need some common monitoring locations. So the question about sediment, of course, we can look there, but I think we need to narrow down to a few key locations. So we've narrowed down to the influent of the wastewater, the effluent, and the surface water as key locations. Of course, if funding allows, you can look at more locations. I think the question about the fish is a good one. It brings to light that wildlife is an important aspect. I think we assume that it's only farms and wastewater plants, but the wildlife are basically a vector that can distribute the antimicrobial resistant bacteria. And you'd be surprised what you can find in locations that you would assume are pristine and remote, but they're not because of migrating birds. As far as what to monitor, I'm glad that the point was brought that E. coli, of course, has advantages, but it's not going to tell us everything we need to know, right? So if you're in a resource limited situation where there's one thing you can monitor, E. coli is a good choice because most laboratories are configured for E. coli testing. And there's a lot of interest in E. coli with the WHO tricycle protocol. There's at least a standardized method and those data are comparable. But I agree that ideally we should expand, and we do have an article in review right now that looks at Aeromonas, Pseudomonas, and Baumani, Acinetobacter, as organisms that have more of an ecological niche and potential to acquire resistance in the environment. So I think those are important to consider. But in general, I think a tiered approach, depending on your resources, and no matter where you are in that tier, coordination so that the data, you have common methods, common reporting units, there's sharing of that data, and then that makes it possible to monitor global trends and know where we should focus our attention. And metagenomics, of course, it has tremendous potential, but it's still in its infancy in a lot of ways. And so I think we really need to coordinate scientists in this space. And like I said, I think if we leave scientists to their own devices, they'll just publish more papers that are exciting and interesting. But we need, you know, even though it's non-target and you can profile everything, we still need to sort through everything in terms of what are the actual targets we're zooming in on? What are the reporting units? What's the pipeline, so that we know that these data are comparable? And we do have to be honest about the limitations of the method as well.
Okay, thank you. But just a small question. When you are doing your monitoring, you see if there is a relation, the coexistence between heavy metals and antibiotic resistance. There is a relation or no
yes.
relation? Because, yeah.
Yes, and in the ES&T Environmental Science and Technology paper that I shared that we published in June, we also looked at heavy metal resistance genes, and they showed a very similar global trend that we saw with the antibiotic resistance genes, that there were higher ARGs, there were higher heavy metals. And I think there are a lot of papers in the literature that demonstrate this. And I think what this this reminds us that, you know, even if we do everything possible to have better stewardship of antibiotics, our job is not done. We have to look at antimicrobials more broadly. So heavy metals are one antimicrobial, and they can also impose selection pressure on antibiotic resistance genes, because the ARGs can be co-located on the same piece of DNA. And so I think it takes coordinated stewardship of antimicrobials, including fungicides, heavy metals, antiparasitics. And I think that's why you see on the world stage, and for example, the quadripartite organisms are referring to the problem of antimicrobial resistance and not just antibiotic resistance.
Yeah, thank you.
Thank you so much. So thank you to Sandrine Baron from ANSYS for her question, and also thank you to Professor Poté from University of Geneva for this question, and thank you, of course, Amy, Professor Amy Prudent, for being with us. I have a very small and maybe naive question. It's how, first of all, is the data sharing, the platform you mentioned, WARD, W-A-R-D. So that is a platform that everybody knows about, that is working on that topic. And how is it possible to standardize the data sets? Who decides? Is it a WHO decision, global decision, or is it more national decision or regional? I don't know. Thank you.
That's a very good question. I think in the end, it has to be national and global, especially global coordination. So I would hope the quadripartite agencies would get involved. So we put together WARD as a prototype. So right now it's a prototype, it's publicly available. Anyone can use it. And we have Excel spreadsheets so that all the users enter the data in the same format. And so really this is us proposing the idea, trying to be proactive and push it. If somebody else like World Health Organization wants to take what we've developed, that would be wonderful. But we felt that we had to put out some example of what it could look like, and then that can be adapted, and just to start the conversation.
Okay. So thank you again for being with us this afternoon here in Geneva, and wishing you a good day in Virginia. Thank you. Bye-bye.
Thank you. Merci beaucoup.
Merci. Merci beaucoup. Congratulations. So now we are going to turn to Dr. Annick Langlet from the International Center for Antimicrobial Resistance Solution, ICARS, science lead. I see that you connected. Good afternoon, Dr. Langlet, or good morning for you. And you are going to make a presentation about mitigating AMR in low and middle income countries across the One Health spectrum, using intervention and implementation research. So yes, we see your slides. It works.
Wonderful. Can you also hear me?
Yeah, perfectly.
Great.
Thank you.
Bon après-midi à tout le monde. Je vais parler en anglais
Mais vous
car
parlez
mon
français.
français technique n'est pas assez bien pour cette réunion. Mais je vais changer en anglais et j'espère que la traduction peut me suivre.
Merci beaucoup.
So good afternoon, everybody. Thank you so much for the invitation, especially to Garance. I would like to discuss a little bit what ICARS is, how we've been created, and what we do, and give you some examples of the projects that we are currently working on. So, whoops, let me just go to this. Okay, so ICARS is an international organization, and we work in partnership with governments in low and middle income countries.
I'm sorry to interrupt.
Yes.
We only see slide number 1. Could you please try to switch to slide number 2?
Yes, that's very strange because on my screen I can see it. Let me just see.
Yeah, that's number 3, but that's okay.
Yeah, no, I think it has something to do with the presentation mode. One moment. Let me see if I can fix this. Okay, and then there we go.
Okay.
I think it's working now. Okay.
Thank you.
Yep. Sorry, let me just go back one slide. There we go. Okay, so it's an international organization, and we work with low and middle income countries and governments to develop and test context-specific solutions for AMR. So we do this by providing both the financial support as well as the technical expertise across the One Health sector. So ICARS was initiated in 2018 by the Danish Ministry of Health, but since last year, it is an independent and self-governed organization. And so the largest proportion of our funding is still coming from the Danish government, but we've also managed to secure some co-funding from member states as well as foundations. And we are still very small, so we're about 27 people from 15 countries, but slowly and gradually growing. I don't think I need to reiterate anything about the burden of AMR. I think this was mentioned in many previous presentations today. And I also saw that the previous speaker highlighted this study from the Lancet from 2019. I think maybe just one additional thing to say is that this study also really put the focus that the disproportionate burden that AMR currently poses in sub-Saharan Africa. And I think that's something that we would try to keep in consideration, and also why ICARS is what ICARS is and working with low and middle income countries. So if we talk about context-specific solutions, what is it exactly that we are talking about? And the solutions really come in 3 areas. So they come in infection prevention and control and biosecurity. So both in healthcare settings as well as in environmental settings and livestock and food production settings. The solutions come in the development of new antibiotics as well as vaccines to prevent infection, because we know that one of the main drivers of overutilization of antibiotics is infections that could have been prevented by vaccines. And then the third one is really the rational use and stewardship of antibiotics across the One Health sector. I think one important thing to say is that even though all these things are known, and there's a lot of research that goes into showing the efficacy and the effectiveness of each of these areas of work in reducing both the burden of AMR and reducing utilization of antibiotics, a lot of the research currently comes from high resource settings where the contexts are just not comparable to low and middle income countries. And in fact, even between countries that are of similar income levels, some of the solutions might actually not be context specific. So there's really a need to adapt and contextualize each of the solutions to individual countries and even maybe subnational regions. So when ICARS looks at the bottlenecks of why successful solutions are not being implemented, or why successful interventions are not being implemented, we really see that this comes in 3 areas. So the first one is really a lack of political and policy commitment. And this comes from the highest level of government down to also more localized government. So there still exists a poor understanding of the consequences of AMR. And there's also a lack of a convincing business model. So how can you really motivate governments to buy into solutions for scale up to mitigate AMR? And if this this evidence isn't provided in a way in which it makes sense from an economic perspective, oftentimes governments might not even buy into it. The second reason we see in terms of implementation bottlenecks are a lack of local ownership, engagement, and behavior change. And the reasons for these are varied, and they will also vary between stakeholders. But we think that they are partially attributed to the fact that there's suboptimal knowledge, attitudes, and practices on antimicrobial resistance, as well as the consequences that it poses. There's a lack of acknowledgement of the need and the importance for implementation research to get sustained change. And when I say implementation research, what I really mean is why research that really focuses on why or how solutions can be implemented better, or why they are not being implemented better. And there's also a local lack of capacity in actually conducting this implementation research. And then finally, which I'm sure goes quite logically following from this, there's a lack of human infrastructural and operational resources to really support implementation of successful interventions. So if we really want to talk about developing sustainable solutions for antimicrobial resistance, these are the 6 factors that have to be included. A political will, an ownership throughout the whole stakeholder chain, so from the highest level of government down to the individual person who is expected to implement the solution. They need to be context specific, because what works in one setting most likely will not work in another setting. There has to be a country capacity to implement the solutions. And we need to understand behavioral aspects of why and how solutions can be better implemented. And finally, they need to be cost effective to have a very strong business case on why a scale up and support for these specific interventions is relevant. Now, ICARS takes quite a unique approach to how we do this compared to other larger funding and technical expertise organizations. So we really try to develop projects using a top-down and bottom-up approach, and that's what you see depicted here on the right-hand side. When we refer to a top-down approach, it means that the buy-in and the request for the project comes from the highest level of government, so a Ministry of Agriculture, a Ministry of Health, a Ministry of Environment, where they express the priority that they have, and that this priority is also reflected in their national action plans for AMR. We feel that really securing this commitment from the ministerial level is crucial to make sure that whatever intervention is tested and the implementation research that's conducted around it is accepted and the results are trusted in order to be able for that level of government to support further scale up. Then the bottom-up component is really to include stakeholders from on the ground, and that includes local universities and research institutions, but also all the stakeholders that are potentially affected by an intervention and a solution, so that you're really including all levels of people and organizations that need to be involved in order to really bring these solutions to scale. In addition to this, we obviously also work with international and national partnerships, including REACT, ILRI, so that's the International Livestock Research Institute, the Fleming Fund, the quadripartite, GAMRIF, etc., to make sure that none of the solutions and activities that ICARS is implementing are in duplication with what is already ongoing. And I think already from today, there's a lot ongoing. So if I could maybe just draw a little bit away from ICARS as an organization and talk about how we define implementation versus intervention research, because I think that's not always necessarily super clear for everybody. So if we talk about intervention research, we have an intervention which you see depicted here on the left-hand side, and then we look at patient outcomes related to that intervention. What we're really curious about is does whatever intervention that's been implemented either improve clinical symptoms? Does it improve the health status? Does it improve outcomes or mortality or functioning of whatever you are looking at? So this could either be in poultry, or it could be in pigs, or it could be in humans. You might also have an intervention that's very focused on bringing about behavior change. So for example, if you're looking at an infection prevention control type of intervention at a hospital to see if monitoring hand hygiene will improve the adherence to hand hygiene, that would be an intervention around behavior change. You could also look and measure the improvement in knowledge, attitudes, and practices, and then a decrease in morbidity and mortality. So then what is the implementation research component that links to this? And implementation research then is really to try to understand how to achieve all of those improved outcomes that I just mentioned. So what needs to be done to adopt the intervention in the target group where you're studying it? How can you ensure that once the intervention is implemented, that there'll be a wide system penetration so that it doesn't just remain a very localized intervention, but that it actually seeps out into other structures in the same area or in the same country? What is required to achieve a higher coverage of your target population? And what is required to implement the intervention the way it's supposed to be implemented? And will you be able to reach the risk population with the intervention that you've laid out? And if not, what is needed to ensure that that happens? And then finally, what is required for scale up and sustainability of the intervention? And these will be questions much more around how much does it cost? Is it cost effective? What kind of policy systems or legal frameworks need to be in place for this to be implemented? So in implementation research, we really try to look at it solutions and interventions for mitigation of AMR in a much more comprehensive and holistic way. Now, despite our very young age, ICARS at the moment is working in 33 projects in 15 countries with approximately 70 research and ministry partners. And some of the dots you see here are reflected where we are working at the moment globally with some of the details of the projects that are associated with them. I won't spend too much time on this slide because I'll just highlight 3 of the projects across the One Health spectrum to give you a better sense of what that looks like. So the first is a project which is currently under implementation in Georgia, looking at the use of antibiotics for surgical antibiotic prophylaxis. Now, what happened is that the Ministry of Health of Georgia approached ICARS with this concern of the overuse of antibiotics in hospital settings. And then through an approximately 8-month co-development process together with ICARS, the project was narrowed down to really focus on the use of antibiotics for surgical antibiotic prophylaxis because it was a feasible thing to tackle, but it was also needed and acknowledged as one of the bigger problems at hospital level. So the problem that was defined was this overuse of antibiotics for surgical antibiotic prophylaxis because the country lacked specific guidelines and regulations. And the project is actually looking to develop these SAP guidelines, which have now been developed, and then to implement them in 10 Georgian hospitals using the WHO Antimicrobial Stewardship Toolkit for low and middle income countries. So the participants for this project, both in the co-development of it as well as in the implementation of it, include the Ministry of Health, universities in Georgia, hospitals, and it's co-funded and facilitated by ICARS. But one component of this project, which really looks at the behavior change and this part of the implementation research, is actually being supported by WHO regional office in Europe. So the expectation from this project is that there'll be around a 60% compliance with these new antibiotic prophylaxis guidelines in surgery within 12 months of launching the intervention. And we also hope to identify the barriers and facilitators that towards implementing this antimicrobial stewardship component in these surgical departments, as well as a cost-benefit analysis, which will help us to advocate towards the Ministry of Health that it is an intervention that is worth scaling up to other hospitals in the country. From a veterinary perspective, at the moment, we have started working in Tanzania to optimize vaccination and biosecurity regimes in commercial poultry production. And again, this is a project that was co-developed for the duration of 2021 and is currently under implementation. And through this co-development process, the problem that was defined was that there was an increased demand for poultry produce, but because of that, the risk for poultry diseases and proper prevention and control measures are not instituted. So you have an increased demand for poultry meat in Tanzania, which is leading to much larger poultry farms getting instituted, but potentially with not the necessary prevention and control measures that are required to reduce disease incidence, which by default then ends up leading to an overutilization of antibiotics to mitigate disease and outbreaks. And so this project is really looking at optimizing a range of vaccine and biosecurity interventions that are available, that are evidence-based, but have not actually been used within the context of Tanzania. And we are also including a social and economic case for sustainable investment in vaccines and biosecurity for the government going forward. So our partners in this project include the Tanzanian Ministry of Livestock and Fisheries, the Ministry of Agriculture, Sokoine University of Agriculture, Irrigation, Natural Resources and Livestock in Zanzibar, and the Zanzibar Livestock Research Institute. And we expect that the project will lead to an overall reduction in antimicrobial use, a reduction in poultry disease, which also translates then to an improved productivity of those farms, as well as an increased local capacity around these interventions. And then finally, and this builds off nicely from the previous presentation around wastewater, this is a project that's being supported in Ghana, which looks at the removal of AMR genes and bacteria from wastewater. So the problem that has been defined here is really around the wastewater from AMR hotspots, so hospitals, nursing homes, and slaughterhouses, and that these effluents are just being discharged directly into the public sewage system. So the project is looking at piloting wastewater treatment technology in Ghana, which combines ozonization, oxidization processes, UV irradiation, and membrane filtration to destroy resistant bacteria and facultative pathogenic bacteria in wastewater. And you can see here, this is a project that's being conducted in Ghana, but as part of a much larger JPI-AMR consortium, including partners in Germany, Norway, and Kenya. And so we hope that this project will deliver on some type of a source-oriented approach to wastewater treatment and potential commercialization of this technology in a low and middle income setting such as Ghana. So I hope I've given you a whirlwind tour of what ICARS is doing, and I'm very happy to accept any questions if there are in the room.
Thank you so much for the presentation, because if you could share it with us too, that would be really valuable for all of us.
You already have it. Yeah.
Thank you. Is there any question? Yes, Professor John Potet from the University of Geneva would like to ask you a question.
Okay, thanks for your presentation. My question is for the removal of AMR from wastewater of Ghana. There are some wastewater treatment plants. This is my first question. And secondly, in the receiving system, what is the receiving system there? A river, a lake, and what can be the impact of the antibiotic resistance gene according to the presence of receiving system? Because if you propose to remove, you should evaluate firstly the potential impact. There you did some research or just the simulation or the transfer of a technology from another country, or exactly you know what is the capacity and efficiency of a wastewater treatment plant in Ghana? Thank you.
Thank you so much for the question. Unfortunately, I'm not really in a position to answer these detailed questions. My email address is on the first slide, and if you would like to email me your question, I'd be happy to send it to the person who would probably be able to answer much better than me. Sorry for that.
Okay, yes, because I am working in Africa for the monitoring of bacteria and antibiotic resistance genes in the wastewater. And for that, for me, before implementation of a technology, I have firstly to evaluate the potential impact.
Yeah, thank you so much for the question. Yes. I'm only an epidemiologist, but if you email me, I will make sure it ends up with the right person.
Okay, thank you.
Thank you so much, Professor. And I like very much your answer that you're only an epidemiologist. I mean, okay, I'm only a journalist. So thank you so much for being with us this afternoon in Geneva. And wishing you a very good day over there. I now will ask our friend Garance Upfam, who did organize this day here at the Geneva Press Club in Geneva, to introduce our next guest, Professor Joseph Allen. Garance, the floor is yours. I suppose that Professor Joseph Allen is connected.
Thank you very much.
Yes, he is. I see him waving.
Well, thank you very much, Professor Allen. You are from the Harvard T.H. Chan School of Public Health in the United States, and you're intervening here also because you were chair of the task force on safe work, safe school, and safe travel from the Lancet COVID-19 Commission, which was absolutely a groundbreaking document looking over what was right and what was wrong in our approach to COVID-19. So I'm very, very delighted to have you here with us today. Go ahead.
Well, thank you for that introduction, and it's nice to be here with everybody today. I'm going to talk about a few aspects of our work on the Lancet COVID-19 Commission Task Force on Safe Work, Safe School, and Safe Travel. For background, I'm a professor at the Harvard School of Public Health. I direct Harvard's Healthy Buildings program. I've been doing investigations of sick buildings for over 20 years. I've written a lot of articles in the popular press, New York Times, Washington Post, Financial Times, with strategies for risk reduction at work, at school, on airplanes, on buses, in cars. In addition to my role in the Lancet, I'm an advisor to Governor Baker in Massachusetts, a state in the United States, and I've been working with the US White House COVID coordinator on what the White House is calling their Clean Air in Buildings Challenge. And I want to just mention that this is a really important moment, at least in the US context, that the pandemic response from President Biden in the United States now includes buildings and clean air in buildings as a fundamental pandemic management strategy, along with vaccines, therapeutics, testings. But it's a really important moment, and I'm going to tell you why and give you some tips about our latest reports from this task force. First and foremost, in understanding how to control risk or mitigate risk indoors, we first have to understand how this virus is spread. That seems obvious, and it should have been obvious. what should have been obvious from the beginning is that we have a novel respiratory virus that's novel to our immune systems, but not novel in terms of how it's spread. This virus, SARS-CoV-2, is spread nearly entirely indoors in places with poor ventilation or poor filtration. It took the World Health Organization and organizations like the United States CDC over a year to recognize that airborne transmission is the dominant mode of transmission. At the beginning of the pandemic, we had a big focus on droplet transmission and fomite transmission. As a result, a lot of the guidance failed to include ventilation and filtration strategies. If you think it's droplet transmission, then the guidance is stand 6 feet away or 2 meters away. If you think it's fomite transmission, you're going to clean surfaces, wash hands frequently. And we saw lots of poor practices there too, in terms of over cleaning or spraying chemicals in the air. This is a project I worked on with the New York Times that we wrote about, not the New York Times article, but we wrote about the fundamentals here in several of the articles we published on my task force and that made it into the full commission report. This depiction here is what's called a computational fluid dynamics model. It is modeling tracers of respiratory particles, respiratory aerosols, showing that very quickly, respiratory aerosols travel beyond 6 feet or 2 meters and will accumulate indoors in places with low ventilation or low filtration. This means that we have the potential for far field transmission, transmission beyond close contact. When you increase ventilation or increase filtration, you can reduce this concentration and therefore reduce risk. I'm showing the New York Times article because I think it is one of the best messaging tools to show what's actually happening indoors with this virus and all respiratory viruses that transmit. The reality is we're all changing. When we're sharing a room together, we're constantly breathing in air that just came out of the lungs of other people in that room. If it's a poorly ventilated room, it might be up to 5% or more of the air you're breathing just came out of the lungs of other people in that room. When we think about it this way, it becomes obvious that the building matters for controlling transmission in schools, homes, offices, airplanes, buses, taxi cabs, cars. And importantly, this applies to other respiratory pathogens like influenza. I brought my task force together this summer to produce one of our last 3 reports. And we really tried to simplify this. And we asked ourselves, what are the first 4 strategies, building strategies, that every building should pursue to reduce risk from COVID-19? And we came up with these 4, and I'm going to talk about them in a little bit of detail, and I'm happy to answer more questions. The first is commission your building systems. 2, maximize outdoor air. 3, upgrade your filtration. And 4, supplement with portable air cleaners where needed. Number 1, I think, is the most important. There's a reason it's number 1. The idea of commissioning your building systems is similar to the idea of giving your car a tune-up. People who own cars or drive cars know that the performance of the car changes over time, and it won't function as well unless you give it a tune-up. You check the oil, you change the oil, you check that the engine is functioning properly. The same thing needs to happen for buildings for this reason. Buildings are designed to a particular standard, but their performance changes and gets worse over time. Right now, we have a virus that's transmitted indoor. We have ventilation standards that I'll talk about in a second that are too low. And even worse, building performance has dropped over time. The single most important thing we can do is commission our buildings, give them a tune-up, bring them back to the way they were designed. This helps reduce risk from COVID-19, improves overall indoor air quality, and very importantly, is also a strategy that helps with our climate goals. Commissioning your building saves energy. Therefore, it saves money. Lawrence Berkeley National Lab of the United States estimates that the return on investment, so after you do the commissioning, how long does it take to recoup the energy savings, is just a couple of years. So this strategy is good for COVID, good for influenza, good for overall indoor air quality improvements, saves energy, saves money. The first step every building should pursue. 2, we need to maximize the amount of outdoor air we're breathing in, bringing into buildings. For decades, we have known that higher ventilation rates are associated with reduced risk of influenza transmission. We saw higher ventilation rates associated with reduced risk from SARS-CoV-1. We've seen over the past 2 years, higher ventilation rates associated with reduced risk from SARS-CoV-2. In addition, there are multiple benefits to higher ventilation rates. Fewer missed school days, fewer missed work days, better cognitive function. Students in classrooms with higher ventilation, more outdoor air, perform better on math tests and reading tests. That's number 2. Number 3, we need to upgrade the level of filters in our building to what's called a MERV 13 filter or something similar. Currently, our buildings use low-grade filters, typically a MERV 8 filter. MERV is just a rating system. A MERV 8 filter captures approximately 20% of airborne particles. A MERV 13 will get you 80 or 90% capture efficiency. Right now, most buildings use filters that are designed to protect equipment and not designed to protect people. We need to increase the level of filtration in our buildings. 4th, if your building can't achieve these higher ventilation rates or higher filtration rates, we need a very good strategy with a strong scientific basis is the use of portable air cleaners with HEPA filters, HEPA high performance filters. These are relatively low cost. In under-resourced countries, you can build these yourself, even cheaper. And they can be very effective when they're sized right for the room. And we release guidance on how to size a portable air cleaner correctly for a room. In addition to the benefits against COVID-19 or SARS-CoV-2, portable air cleaners and better filtration capture particles from outdoor air pollution or particles generated during a wildfire or allergens that are in dust in the indoor environment. So this is another strategy that comes with multiple benefits for health beyond SARS-CoV-2. An area that most of the world has significantly failed on during the pandemic is establishing targets for clean air delivery rates. In other words, we've been talking about bringing in more outdoor air and better filtration, but the obvious next question is how much? Here's an article I wrote and published with a colleague in the Journal of American Medical Association recommending 4 to 6 air changes per hour. Right now, major organizations have still not published targets for people. And I will let you know that my task force, the Lancet COVID-19 Task Force on Safe Work, Safe School, and Safe Travel, is producing a report right now with more detailed recommendations for targets that will be released very shortly, maybe even tomorrow. Before I take or stop to take questions, I want to frame this in a bigger way. For decades, we have ignored the importance of better ventilation rates in buildings. 100 years ago, ventilation rates in buildings were set based on controlling infectious disease transmission. Somewhere along the way, we lost our way. Approximately in the 1970s or 1980s, in response to the global energy crisis, we started tightening up our building envelopes, lowering the amount of fresh air we brought into buildings. This ushered in the sick building era. For 40 years, we have been in the sick building era. By design, we are setting targets for our buildings that are not based on the best scientific and health evidence. With colleagues from around the world, including members of my Lancet COVID-19 Commission task force, we wrote an article in Science calling for a paradigm shift to combat indoor respiratory infection. I think a key point we make in the article right up front is that this is a tractable problem. We can solve this problem. We know what the problem is. We have the technology and the solutions available today. And when we act, we see an impact. If you look at the public health gains made over the past 100 years, we have made enormous gains in many parts of the world around better water quality, better sanitation, better food safety. Indoor air has been ignored as part of a comprehensive pillar and strategy of protecting and promoting good overall health. Delighted to share the other, or introduce the members of the task force representing scientists from around the world and I guess with degrees and backgrounds in engineering, indoor air quality, public health science, occupational health science, pediatricians, business leaders. So we put together what we think is an excellent group of scientists and experts with backgrounds really relevant to the topic. And we've released several reports. We have one more coming out on targets for ventilation rates this week. And very soon we'll have our final report from our task force with our final recommendations, all of which have appeared in the full Lancet COVID-19 Commission report. So I want to thank the Lancet for inviting me to participate and lead or chair this important task force. I want to thank Jeff Sachs for his leadership as the chair of the Lancet COVID-19 Commission. And I'm happy to answer any questions you have on this topic. Thank you.
Thank you so much for this very, very interesting presentation, particularly for Geneva-based people that followed COVID-19 problems since, I would say, day one here with attending press conferences from WHO to see the evolution and also wait. So I have a question. I know I'm only the moderator, but I'm a journalist. So I'd like to know why it took so long to admit the fact that COVID was airborne.
I have a couple ideas for why that is, but I will say this. We knew it was airborne right in the beginning. The first piece I wrote was published in Financial Times, February 9th, 2020. This virus is spread through the air. Ventilation and filtration are important. How do we know? We could look at influenza, we could look at MERS, we could look at SARS-1, but importantly, we had this information from the first outbreaks. Think about the Diamond Princess cruise ship, or in the United States, we had an infamous choir outbreak. You can't have a 90% attack rate and explain that by shared surfaces. You can't have 90% infected because everyone touched the same doorknob. You can't explain that from droplet transmission, which would require close contact. I think the issue is this. The medical community had largely accepted droplet transmission as the dominant mode of transmission, meaning large droplets that settle out of the air. The reality is we're emitting respiratory droplets and aerosols of all different sizes. Some big particles will settle out of the air. Most are much smaller, and the virus is concentrated in those smaller particles. These smaller particles travel beyond 2 meters or 6 feet and stay aloft for 30 minutes or an hour or more. Basic physics told us that airborne transmission was dominant. I think there was a dogma. I think there was an accepted practice of droplet precautions that had so penetrated how we think about infection control around respiratory diseases. Even look at what happens in a hospital or healthcare setting with what is called aerosol generating procedures. So there's certain procedures what the medical community knew generated aerosols or thought they knew generated aerosols, and protections were put in place only for that. The reality is we're always emitting and generating aerosols. Just talking is generating aerosols. Just breathing quietly is generating aerosols. The good news is this: the scientific and medical literature is being rewritten, acknowledging the importance of aerosol or airborne transmission. Articles published in New England Journal of Medicine, The Lancet, JAMA, Science, by top experts around the world have now established this as the dominant mode of transmission for this virus and a critical mode of transmission, if not the dominant mode of transmission for other respiratory diseases.
So, Garance, you have a question.
Well, Catherine, you will remember, because you organized this, a discussion with ourselves, our task force, in which I spoke on airborne transmission. What was it, a year and a half ago with ACANU, remember?
Yes. ACANU is the Association of Correspondents at the United Nations in Geneva. Yes, we did organize that.
So I'm not famous as you are, Professor Allen, who have followed your scientific publications, but looking again at the science publication already way back when, I remember a seminar. I was in a webinar with Australian University in which they had people from China online, and a group of clinicians from Wuhan hospitals stated that within a few days of the epidemic, they found that they had cases of COVID-19 in the administrative part of the hospital. And so what did they do? They shut off the air conditioning. That was way back when. That was February 2020. But somehow this information didn't get through. And I hope you can stay for my presentation now, because that's my topic, and to expand it onto tuberculosis today.
Yeah, I'll stay, and I agree with you. I think all of the evidence we needed was there in the beginning, and it was hard to break through. I mean, I'll tell you, I give a lot of credit to the Lancet and Jeff Sachs for selecting me to participate in this, because when I was invited to chair this task force, it was hotly debated about the mode of transmission. And Jeff knew where I stood, and I assembled a group of scientists and influential scientists to really look through the science and wade through it. So I'm proud of the work. I think the very first report that our Lancet COVID-19 Commission issued as a commission, which was February 2020, talks about airborne transmission and aerosols. So we did our best to get out there. And I want to leave on an optimistic note. I feel like we've moved on. It's now accepted. In the places that didn't accept it, it's moved on. In places like Japan, they had accepted this airborne transmission right from the beginning. So this is not a global phenomenon, but in many parts of Europe, and particularly in the US, airborne transmission was ignored, but we're moving on. I think many good organizations and even private companies have recognized now the importance of good ventilation and good filtration and these overall healthy building strategies to improve the condition of people indoors against infectious diseases, but also to improve overall well-being and health.
Shall we go?
Yes, is there another question? I have a question again concerning the architecture of the hospitals. A WHO doctor, I won't mention the name of the person, told me that the architecture of the hospitals should be changed into what used to be. That means that before, people were building different pavilions to avoid the spreading. And that now that you are, that we are building those huge buildings with aircon and those stairs, that was the best way to spread all kind of diseases and infections. What is your opinion about that? And do you think that we should go back to that kind of architecture, in fact, to avoid what you just mentioned, to have all the air cleaners and have those filters? We know that it's very easy to talk about that on paper, but when it comes to reality, it's another story.
Yeah, I think that's a good question. And, I actually think the current practices in hospitals, hospitals pay attention to ventilation and filtration. In fact, the leading ventilation standard for healthcare already has elevated ventilation rates for clinic rooms and patient rooms, and even higher standards for things like surgical suites. So most everywhere else we spend our time, homes, offices, schools, are much, much, much below this. So I actually think hospital design would still benefit from these basic strategies. Bring in more outdoor air, better filtration. It doesn't have to be the use of portable filtration. In very high-risk locations, there are other strategies you can do. For example, in an airborne infection isolation rooms, the target is over 12 air changes per hour. Well, in a school, it's about 3. In a home, it might be half an air change per hour. So I think most important, I think hospitals are starting to understand that they have essentially 2 different standards. A general standard, which is above the minimum, and a high standard for high-risk locations. During a pandemic, what we found with SARS-CoV-2 is that everywhere was high risk in a hospital because a lot of people had it or were going there for it. So we could bring up even these good standards to even higher standards. I think the biggest benefit, though, from a public health standpoint, would be to bring the ventilation rates that are way too low in schools and homes and offices and bring them up more like what we'd find in a patient room. This is particularly important in high-risk locations like senior living or congregate care settings. The most important risk factor for SARS-CoV-2 is age. And these locations also have lower ventilation rates. We need to treat them more like hospital or healthcare settings and improve the air quality in places with seniors and in schools to address this.
Thank you. Garance.
Should I start a presentation?
No, but I mean, do you have a question for Professor Joseph Allen? No? Any other
Well,
question?
are you staying with us, Professor Allen? Are you staying with us?
I'm going to listen to your presentation, sure.
Okay.
So thank you so much for your presentation and answering our questions.
Thanks for having me.
No, pleasure. Garance, the floor is yours.
Well, I'm president of the AMR think tank, Geneva International, which is a group of experts from all over the world trying to engage in brainstorming. I'll wait for my slide. And my topic is airborne pandemics from SARS-CoV-2 to multi-drug resistant tuberculosis, and how armed conflicts anywhere and in Europe today can aggravate the problem of AMR and of the risk of airborne pandemics. Next slide, please, Thomas. Now, armed conflict are usually associated with fast and dramatic epidemics. But what is overlooked, and we published, in my group, we published an article last year in AMR Control 2019 on the role of armed conflicts in driving low and covered threats, such as AMR, because this is not looked at. So the media, if you look at the media report on armed conflicts, we always talk about the number of deaths. I'm of the age to remember the Vietnam War when I was in the United States of America, and we used to have body counts every day. But in fact, for every death in an armed conflict, you have an estimated 10 people who are wounded. Of course, the problem is, as identified by the European Centers for Disease Control today in Europe, that people wounded in the Ukrainian conflict are going into refugee camp, and then they end up in European hospital system, and nobody is looking at that, but the ECDC is starting to publish and saying there is worry because those wounded who were not able to get proper care immediately may bring with them, are bringing with them, drug-resistant bacterial infection. And this, if you remember, in Europe a few years ago, there was a fire in a nightclub in Romania in which several hundred people were severely burned. And so throughout the EU, helicopters flew people to all the available heavy burn facilities in Europe. And in every facility, Dr. Monet, head of AMR for ECDC, told me, in every facility in Europe, those heavily burned persons brought with them drug-resistant bacterial infection. So the situation in a country like France, for example, which has a high level of IPC, infection control, high level infection control in Switzerland, there is no such thing as protection in one single region, in one single country, if your neighbor does not have the same level of protection. Next one. So the Ukrainian armed conflict is causing a surge in AMR in the European region. The same, of course, is true, though it's not monitored, for the wars in Yemen, in Syria, and everywhere else where there is conflict. AMR control, I would say, demands peace. Now, today, the one topic I would like to talk about is the covert threat carried by an airborne pathogen, in that case, tuberculosis. Before the war in Ukraine, both Ukraine and Russia were among the countries listed by the WHO as countries with the highest in the world totally drug-resistant tuberculosis and multiple drug-resistant tuberculosis. All right? There are 20 countries on the list. Those two were on the list. And it was really a real concern in Russia, because in Russia in 2017, the state organized the first ministerial summit on tuberculosis, which was attended by all developing countries, but not many from the European Union. So the breakdown in health services in Ukraine and the exodus of 8 million refugees into Europe over the past year means a high risk of spread of tuberculosis. Now, I won't go into the details of the Lancet Commission 2019 report on airborne transmission, because Professor Allen did that very well. I want to say a personal story. In the 1950s and 60s, I used to travel every year between Geneva and Boston, Geneva and New York, Geneva and Washington, having an American father and having a polio problem, to visit hospitals and so forth. And at the time, smoking was allowed. You could smoke on a plane in the 50s and 60s. And so my 2 or whatever trips every year, I remember being literally smoked in. I mean, it was fairly awful with those very long trips to be there with people smoking all around you. It was absolutely terrible. So I remember that, and if you listen to, not to physicians, I'm sorry to say, but to physicists today, because those are people working in the physics of today, of this century, that we have been able to identify how airborne pathogens travel and how they are transmitted. Now, excuse me, can you go to the next slide? I'm on the next slide already. Now, I want to show that this is what I was talking about. This image was published, this photograph was published in Nature in a major article going through the history of the misunderstanding of what airborne protection is. But what was not really identified in the Nature article, in my view, I'm less optimistic than Professor Allen, is the irony of this kind of picture. We are in a school cafeteria in South Korea, a very highly developed country with one of the really good, high-performing healthcare systems, such as we have in Switzerland or in France. And look what they did. Now, imagine if we had had that kind of response against tobacco smoke. Instead of banning tobacco smoke in closed building, maybe we should have had those dividing plexiglass, plastic shield. Think of it. Because we have seen it in McDonald's Geneva. We have seen it in McDonald's all over the place. We have seen it in cashiers. We have seen an epidemic of plexiglass, of shield, the plastic shields that are supposed to protect us from COVID-19 virus. Now think about it. Think about smoke. Imagine those kids, you have smoke around. Do you think those poor kids that are in those yellow boxes would be spared from tobacco smoke in the room? Well, all of us who have smoked in the past know how smoke creates volutes in the air. Okay? Those are small particles that are carried in the air that are swirling around. You can see that using, fluid dynamics, fluid mechanics, physics, and this is what a number of laboratories are doing all around the world, is to map out how very fine particles can be smoke, it can be any kind of viral particle, it can be any kind of bacterial particle, is traveling from the person's breath. And for those of you who don't smoke, never smoked, if you think of your breath in a very, very cold winter, when you walk around, you'll see your breath in front of you, how funny it's swirling around. This is the way pathogens spread. Now, okay, next slide. Sorry. Now, Professor Allen went through some of the errors, terrible errors that were made. I don't think that there has been a real understanding of the depth of the catastrophic errors that were made in public policies today. Now, the best center, one of the best centers to analyze airborne transmission or our air pathogens, airborne transmitted travel in the air, is a lady who is called Professor Lydia Buruiba at the Massachusetts Institute of Technology, which is one of the most advanced laboratories in the US and in the world. And with Randall of Virginia Tech, we heard some people from Virginia Tech before, because Lady Buruiba has been working on that and publishing extensively. And I think her best article, which I can send you if you write to me, is an article which is an historical overview of the comprehension of airborne contamination from 1800 to today. And what does she say? She said, advice based on the 18th century grasp of nature is 1 or 2 meter social distancing. Does that ring a bell? All the advice you see today, everywhere in public health, is the 1 to 2 meters. You know, we in the world, we applied that at the time of the Spanish flu in 1918. You know, beds were set 3 feet apart because it was assumed that soldiers would not catch the next soldier Spanish flu. We know that led to 50 million deaths at the time, right? That was already the 1 to 2 meter social distancing applied exactly a century ago. Why are we stuck there? I mean, this is a real question. Now, I'll go into tuberculosis, because last year at the World IUATLD conference, which is International Union Against Tuberculosis and Lung Disease, this NGO is an NGO that is masterminding practically most of the tuberculosis problem, most of the tuberculosis program throughout the world. So the IUATLD is not a small partner in tuberculosis control. It is the major partner, much bigger in terms of its action to the WHO TB program. And so at the IUATLD conference in October of last year, exactly a year ago, a year and 2 weeks ago, a South African research team, which made headlines, they reported that physics experiments demonstrate that tuberculosis is airborne. It is a misunderstanding to think that somebody with tuberculosis who starts to cough is the major culprit for the dissemination of tuberculosis. Because physics experiments show that some people have tuberculosis, but they don't cough. And that even with coughing, the amount of dangerous pathogen-carrying particles transmitted at a close range is only a very small, about 10%, a portion of the total amount of infectious particles that will be disseminated in a room from simple breathing. This is an article that's outstanding, that is really worth reading. We're not talking about coughing. We're not talking about sneezing. We're not talking about singing, talking loud, as I am trying now. We are talking about, we're not even talking about forced breathing, which is a medical procedure. We're talking about normal breathing. A normal human being breathes 20,000 times a day. I mean, this is normal, this is understood. However, the way we're going about prevention of tuberculosis or prevention of other airborne diseases is based on the understanding or the misunderstanding of science from 1800. We are 2 centuries late in understanding airborne transmission. So I would like to say that I'm not completely optimistic. I think these winds of change, which is Professor Allen demonstrated very well, they are winds of change. However, it's going to be difficult to shake our public health institutions, whether at the UN level or at the national level, from a business as usual approach, which is focusing on a misunderstanding of airborne transmission as on a short distance, right, or just immediately around you, and that we need to really try to reach the public and try to reach our policymakers to have a change in emphasis. And change, of course, includes change in hospital management, because even if we have good air filtration, to the extent we have overcrowded emergency wards with hundreds of people waiting in hallways, one on top of the other, we are creating a problem. I remember seeing, I used to work in tuberculosis for some years as an advocate and economist, and I've seen so many images and seen so many cases in Francophone Africa where you have the waiting room for suspected tuberculosis cases, and you have a room like this which is closed, which is completely overcrowded. Well, I have news for you. If you have 3 cases, real cases of tuberculosis in the room, you're going to contaminate 15 people just by sitting there waiting for the test. And it's absurd, because in Africa we have room. We can keep the windows open, keep the doors open, have the maximum circulation of air, never close people in the room. One of the reasons why Florida has such a high percentage of COVID-19 in this part of the United States is also, and in general in the US, because of the overuse of air conditioning. There's nothing better than air conditioning if you want to share airborne pathogens one with the other. So I think that if we're serious, we should try to close down air conditioning. And I want to close on 1 or 2 things. One is that the WHO just published in a book on AMR. You're not, tu me suis pas, hein? Sorry. Well, you're in airborne. Okay. AMR TB pandemic threats is what I talked about. Go back. Recule. Voilà, I was talking about that before. I'm sorry that my slides are. Okay. So the AMR TB pandemic threat. I'd like to quote Professor William Hazeltine, who wrote in Forbes, "The next AMR pandemic may well be tuberculosis." And he published that after, in the wake of their publication of this major South African study on tuberculosis, and before the Ukraine war, before the influx of refugees, in which you can see that I think nobody in Europe undertook any kind of follow-up of the refugees, which we should have had if we were serious about controlling epidemics everywhere, right? Because in the South African study, they showed that people who were not coughing were as contagious as people who were coughing. So there's no correlation, in fact, with the risk. And last month, the Presidential Committee on Antibiotic Resistance of the United States of America, their September meeting, they warned, they said, flu epidemics with opportunistic AMR pathogens will be coming, and the question is not if, but when. And was it at the time, you can see that a few months ago, the White House page that was in March 2022 talked about COVID-19 being airborne and announcing this major funding with HVAC, with the industry of ventilation. I think this is what Alan talked about. However, I think, next slide, I'd like to mention a last thing, which is that the WHO just published a warning on drug-resistant fungi, drug-resistant fungal infection, and notably Aspergillus fumigatus, which the Presidential Committee, PACARB in the US, reported, the CDC reported, that in some instances, and they said the US has very little laboratory capacity to identify A. fumigatus, but they found that sometimes up to 30% in some cases of the COVID-19 patients didn't die from COVID-19, they died from A. fumigatus. And it's becoming a major, major problem. A. fumigatus can transmit by aerosol, even though it may not be the main mode of transmission for that, and the load is very large since we have 2.2 million cases in the European Union, and the number of cases that are azole resistant is growing. So I would encourage you to look at this report. Last spring at the WHO Research and Development webinar, the German scientific leader, Dr. Drosten, who was the first to identify how to test for SARS-CoV-2, he called for a lot more research on mucosal immunity, saying, and I think we have to really support what he said, that nasal vaccines would be much more efficient and maybe the only thing truly efficient to stop airborne SARS-CoV-2. And he called for a lot more emphasis to understand mucosal immunity, which for the layman means that a number of pathogens enter us, not through the blood, but first through the respiratory system. And this is where we should have a better understanding of mucosal immunity, of how airborne pathogens contaminate us and lead to disease. Now, there are many R&D public and private groups that are developing nasal vaccines today. China just started with one, there's French, many in the US, and so forth. Did the Chinese understand that? Well, there's a famous book of Bob Woodward on Trump saying that Xi, the president of China, told him, it's in the air. So in fact, what is funny is that the knowledge that SARS-CoV-2 was in the air was actually known way back when, but the response, again, the response is based on understanding of transmission as droplets dropping like with a ballistic kind of effect on 1 or 2 feet away from the contaminating party. And this is not reality. Now, next one. This is just the future plans and project of the AMR think tank. Thank you very much. So you can see what our projects are, and if you want to work with us, you're welcome. Thank you.
Thank you so much, Florence. Bravo. Now we are reaching the end of this day. I think we did a great job, and I would like to thank again, a question. So we have 5 minutes, but please, we don't have to be too long. We have a question from the room.
Je vais poser ma question en français pour être plus précis dans ma question. Elle est pour les 2 orateurs, pour Prof. Alan aussi.
Joseph Allen, c'est ça?
Oui.
Et Garance?
Et Garance.
OK.
Et en vous écoutant, je comprends que on savait beaucoup de choses sur la transmission, on l'a su très rapidement, les choses sur la transmission par les aérosols dès le début. Et plus généralement, il y avait beaucoup de choses qu'on devait savoir, qu'on pouvait savoir. Et quand on se souvient des mesures qu'on nous a fait prendre, d'abord du délai pour prendre ces mesures, puis ensuite des conditions, effectivement, c'était complètement absurde. Au début, on nous disait de ne pas porter de masque. Après, on nous a dit de les porter. Il a fallu se battre pour que les malades diagnostiqués Covid-19 qui rentraient chez eux puissent disposer de masques. Les pharmacies en France refusaient de les vendre parce que le gouvernement avait interdit aux pharmacies de les vendre. Donc il y a comme ça une série, je me souviens d'un papier dans un journal allemand qui parlait d'absurdistan, donc vraiment d'une manière de gérer les choses complètement absurde, et l'histoire d'1 kilomètre autour de chez nous, etc. On voyait bien qu'il y avait des choses qui n'avaient pas de sens. Et bien en même temps, on laissait le métro avec le minimum de rames, et on était tassés dans les rames. La question qu'il y a, est-ce que vous avez réfléchi, parce que j'ai été confronté aussi à ça sur la Covid ou sur d'autres épidémies, c'est qu'on a des connaissances, on n'arrive pas à les faire arriver dans la tête de nos décideurs, ou alors je ne sais pas ce qui se passe, et donc il y a un vrai problème dans la lutte contre les pandémies, c'est transformer des connaissances en bonne pratique, et en manière de répondre correctement à une épidémie, et surtout éviter les interférences de personnes qui ne savent rien et qui parlent plus fort. Donc c'est un vrai problème. Je ne suis pas là pour faire le spectacle, c'est vraiment, pour moi, c'est un questionnement. Est-ce que vous vous êtes posé la question? Est-ce que vous réfléchissez à une manière d'être plus performant la prochaine fois pour faire passer des messages aux décideurs, pour transformer vos connaissances ou les miennes dans d'autres sujets en une politique efficace de lutte contre la transmission?
Merci beaucoup. Thank you so much to Professor Renaud Piarou from Paris, France, Sorbonne. I'd like to know if Professor Joseph Allen did hear the question and did hear the translation. Yes, I see you connected. Have you heard what Professor Piarou said about the fact that apparently we had the knowledge, we had the information from approximately day one, but a lot of things happened during the time, and in the different governments, different countries decided to ask the population, to implement weird things, you know. So can you explain that? And as Professor Piarou just mentioned, would it be possible for the next one that people like you guys, could be closer of the decision makers?
Yeah, I think it's a really good question. So, a lot has been written about what's called hygiene theater, or, pandemic theater, things that people did and people were given guidance to do that didn't have any grounding in science. This is everything from, in the United States, there was guidance to quarantine your mail before reading it, leave it in the garage for 2 weeks. People were washing their groceries, like washing ketchup bottles. We were closing schools for days at a time to fog them. Now, all of that is totally detached from the science of how this is spread. We should recognize there was a lot of uncertainty and panic, rightfully so, early in the pandemic. That said, we had plenty of scientific evidence to establish how it was spread, which then governs which controls make the most sense. I think some countries did a very good job of this. Some did a very poor job of this. Why I'm optimistic about the future is that I think it's unequivocal at this point that airborne spread dominates. And you see, even my country in the US, which was very late to recognize airborne spread, it is now a pillar. The healthy buildings are a pillar of the federal pandemic response. We see World Health Organization talking about this, setting standards. Non-governmental standard-setting bodies are talking about creating new guidance for higher ventilation rates, for infection control. So I hope this doesn't happen again anytime soon. It is going to happen again. But I am confident that it won't take as long to recognize airborne transmission when it's happening and the role that indoor air quality plays in mitigating that transmission. I think we've won that scientific, political, and public argument. The public is now really aware that this is how this spreads.
So Garance, you have something to add.
I thank you very much, Professor Allen, for this message of hope, which I would like to share. I think the presentation was great, because what we really need to do is build more bridges between hard science and the lay public and policymakers. And this is really lacking, and this is something that we have to undertake. And I'd like to close with something that's funny and tragical. We have this epidemic of Ebola in Uganda. We have other epidemics going on. And one of the papers I remember reading from Professor Allen was how toilets were a place where you were most likely to catch COVID-19. And that is very interesting, because that's aerosol. And of course, what is true about COVID is also true about blood-borne diseases like Ebola, and nobody's talking about it. So there's a long way to go. And I want to thank everybody who participated in this effort, because sometimes we feel lonely in fighting for truth. Thank you.
Merci beaucoup, Garance, UFAM. Thank you so much for organizing this exceptional day on antimicrobial resistance. Thank you for bringing so brilliant experts that did share their experience through the day. And I would like also to thank Tobias from the Geneva Press Club, but also the translators for doing a great job through the day. Thank you to all of you online and in the room, and wishing you a very good day if you're in the States, and a good evening if you're somewhere in Europe. Bye-bye.